So, we are at cardiovascular system and we were discussing abnormal ECG. In our previous class, we have discussed the physiological basis of ECG changes in acute coronary syndrome, okay, or myocardial infarction. So, today we will be proceeding with another abnormal ECG, that is heart block, okay, heart block. Basically, it is a conduction block, okay, basically it is a conduction block. So, to know heart block in detail, you need to know the conduction tissues, which I guess you already know, right. So, we have the SA node over here at the level of atria, right atria. From SA node to AV node, we have internodal tract, right. Then this is AV node, which is at the upper part of interventricular septum, and from AV node there is bundle of His within the interventricular septum, and bundle of His, it divides into the left bundle branch and right bundle branch, right, left bundle branch and right bundle branch. What is the purpose of this division? The right bundle branch, it supplies the right ventricle, and the left bundle branch, it supplies the left ventricle, okay. Now, as because you already know that left ventricular muscle mass is quite more than the right ventricle, right. So, we need to have more branches to supply the left ventricle. So, this is why your left bundle branch, it divides into two, right. The anterior part of the left ventricle, it is supplied by the anterior fascicle, and the posterior part of the left ventricle, it is supplied by the posterior fascicle, right. This is conduction tissue and this is meant for conduction of what? Conduction of action potential, yes. So, through this conduction tissues, action potential travels from SA node is not shown here in the picture, from SA node to AV node to bundle of His to right bundle branch and left bundle branch divides into anterior fascicle and posterior fascicle, okay. And the right bundle branch, it has got no further branchings, because right ventricle is small, okay, in terms of muscle mass, and left ventricle is larger in terms of muscle mass. So, it needs further branching. Anterior part of the left ventricle is supplied by the anterior fascicle and posterior part is supplied by posterior fascicle. And I have already told you that the conduction tissues are nothing but the modified myocardium, which have got, you know, more gap junctions, okay, so that they can transmit action potential faster than the normal myocardium, okay. They can transmit action potential faster. Now, say for example, due to any disease process, okay, there is structural abnormality within the heart due to any disease process. It may be myocardial infarction, or it may be other disease process which is causing some pathology in the conducting fibers, okay. So, there might be block over here at the bundle of His, there might be block at the right bundle branch, there might be block in the left bundle branch, there might be block in the anterior fascicle and posterior fascicle as well, okay. So, we call them heart block, right, we call them heart block. So, first let us discuss the AV block. Say AV block, say for example, the block is here at the level of AV node, we call it AV block, and we divide AV block into first degree heart block, second degree heart block and third degree heart block or complete heart block, okay. You do not need to know much details about the blocks, but depending on the criteria, you need to classify first degree heart block, second degree heart block and third degree or complete heart block, right. So, from the name very well, it suggests that the more the degree of block, the more serious the condition is, okay, right. So, for example, third degree heart block, it is a fatal situation and you need to recover the patient by inserting a pacemaker, right, okay. So, anyway, we are coming to it. So, first degree heart block, let us come to first degree heart block. So, by now you know the PR interval, right. What is PR interval? It is from the beginning of P wave to the start of Q wave, it is called PR interval, and the normal value of PR interval is 0.12 to 2 second, okay, 0.12 to 0.2 second, 0.12 to 0.2 seconds. It is the normal PR interval. So 0.12 to 0.2 second is the normal PR interval, correct? Normal PR interval. So if you convert it into millisecond, it will be, say, 120 to 200 millisecond, correct? Clear? This is normal PR interval. Okay. What does PR interval signify? Yes. It is the time within which depolarization wave travels from atria to ventricle. Okay. Because P wave, you know, atrial depolarization, and QRS complex is ventricular depolarization. So the time interval between atrial depolarization and ventricular depolarization, that essentially means the atrial depolarization wave, it takes some time to reach the ventricle. Okay. Atria is initially depolarized, then ventricle is depolarized. So the time interval between atrial depolarization and ventricular depolarization. Okay. Action potential को atria से ventricle जाने में कितना time लग रहा है? That is PR interval, right? And this PR interval is normally 0.12 to 0.2 second. That essentially means 120 to 200 milliseconds. Okay. Now once this PR interval is high, that means atrial depolarization taking longer time to reach ventricle. Okay. Atrial, the action potential which is being generated at the level of SA node, it is taking much time reaching ventricle, right? Okay. So here you see the PR interval is, this is P wave and here is the Q wave. So the distance is PR interval, it is calculated over here is 360 millisecond, which is definitely higher than the normal value, right? Higher than the normal range, right? So here PR interval is increased, and you see everywhere this is P wave and this is Q wave, P wave, this is Q wave. So everywhere it is 360 millisecond. Everywhere it is 360 millisecond. So PR interval is increased. Number one, there are two criteria. One is PR interval is increased and it is constant. Everywhere, wherever you check PR interval, it will come to 360 millisecond. Here is a PR interval again, this is PR interval again, this is PR interval. So everywhere it is 360 millisecond more than normal. We call it first degree heart block. Okay. First degree heart block is not life threatening and the patient can be followed up, right? Okay. And very often there is no symptoms as well. Okay, patient को कुछ symptoms भी नहीं होता है and PR interval is increased, right? So once you do an ECG, the patient is identified as having first degree heart block, right? Usually patient do not have any symptoms for it and there is no requirement of any specific treatment and the condition is not fatal as well, not serious as well, right? And the patient can be followed up further if there is increase in the degree of block, first degree heart block, it may convert into second degree heart block. So you follow up doing an ECG every 6 months or every year, right? Okay. So this is first degree heart block. Clear everyone? So what is first degree heart block? PR interval is increased, number one. Number two, PR interval is constant. Okay. So every time it is 360 millisecond. In our example, it is 360 millisecond. It may be 480 millisecond, it may be 300 millisecond, okay, but constant, right? So this is first degree heart block. Clear everyone? May I proceed? Okay. Now come to second degree heart block. So second degree heart block, it is also called Wenckebach type or Mobis type 1. Okay. So what is happening in second degree heart block? You see initially PR interval is 260 millisecond. Definitely it is more than normal because upper limit is 200 millisecond, right? So you see first it is 260 millisecond. In the next ECG wave, you see it is 280 millisecond. In the next ECG wave, it is 320 milliseconds. So gradually PR interval is increasing, right? Gradually PR interval is increasing and a situation will come when there will be a loss of QRS complex. So P wave will not be followed by a QRS complex, right? ECG में क्या होता है? पहले P wave होता है, फिर QRS complex होता है, right? So P wave, QRS complex. The interval is 260 millisecond. Again P wave, QRS complex. Interval is 280 millisecond. Again P wave, QRS complex. Interval is 320 millisecond. Next P wave, but there is no QRS complex. Okay, so you see this complex, here is a P, but it is not followed by a QRS complex. There is a pause, right? Okay, so the criteria is PR interval is high, but it is gradually increasing until a certain point when one P wave is not followed by a QRS complex. This is second degree heart block. Okay, patient might be complaining of palpitation, these things, right? Okay, so second degree heart block, right? Clear? First degree heart block was PR interval is increased but constant. Second degree heart block is PR interval is gradually increasing until a point when P wave is not followed by a QRS complex. Okay, so you will be getting two P waves consecutively, right? So here is a P wave, again another is P wave. Okay, again this thing will repeat 260, 280, 320. Again this will repeat 260, 280, 320. Again P wave will not followed by a QRS complex. Okay, clear? PR इंटरवल बढ़ते रहेगा तब तक जब तक एक QRS कॉम्प्लेक्स मिस नहीं होता है, ठीक है? सो सेकेंड डिग्री हार्ट ब्लॉक, second degree heart block type 2, here the thing is 2 P wave than 1 QRS complex. Okay, see this 2 P wave and then QRS complex, 2 P wave then QRS complex, 2 P wave QRS complex. It is called second degree heart block 2:1 type. Okay, again 2:1 type. Now third degree heart block. What is third degree heart block? Absolutely there is no relation between P wave and QRS complex. Okay, there is a relation between P wave and QRS complex. पहले P wave आता है, उसके बाद QRS complex आता है, and P wave is the reason for QRS complex. Okay, P wave होता है इसीलिए QRS complex होता है, right? P wave is the cause behind QRS complex, right? So it has the relation. पहले P wave होता है, फिर QRS complex होता है. But here atria और ventricle दोनों में breakup हो गया, right? So atria is beating on its own and ventricle is beating on its own. ठीक है? Atria is saying that मुझे कोई फर्क नहीं पड़ता आप क्या कर रहे हो नहीं कर रहे हो, ठीक है? And ventricle is also saying that आप मुझे फर्क नहीं पड़ता atria is beating or not. Okay? So atria is beating on its own and ventricle is beating on its own. So बहुत मुश्किल है यहाँ पर आप P wave identify नहीं कर पाओगे. So this is P wave, 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 and you see atria P wave उसका एक अपना rhythm है and ventricle has got its own rhythm. ठीक है? But there is no relation. एकदम bizarre है. There is no relation between P wave and QRS complex. This is QRS complex, this is QRS complex, this is QRS complex. Okay, P wave कभी यहाँ पर है, कभी T wave के ऊपर है, कभी P wave यहाँ पर है. Now sometimes P wave is here after T, right? So there is absolutely no relation between atrial rhythm and ventricular rhythm. It is also called the atrioventricular dissociation. Okay, atrioventricular dissociation. Okay, breakup हो गया दोनों में, right? So this is called third degree heart block. It is a serious condition, it is a fatal condition, and you need to insert pacemaker to recover the patient, right? So this much is enough for you at Fast Professional MBBS to identify heart block, okay, to classify heart block, AV block basically, atrioventricular block, right? The block is at the level of AV node, right? Okay, atrioventricular block. So AV block or AVB, in short AVB, right? In short, AVB, right? Atrioventricular block. We classify it into first degree heart block, second degree heart block, and third degree heart block. Okay? And with the ECG, you need to identify what is first degree block, what is second degree block, and what is third degree block. You should be able to identify. Okay? If I give you the ECG strips of a patient, right? A sample ECG, you need to identify first degree heart block, second degree heart block, and third degree heart block. Okay, again we will practice these things in your ECG practical sessions, right? This is the theoretical part I have told, but in practical we have lots of ECGs samples from patients, right? So you need to identify ECGs of heart block, right? Okay, now again coming to another conduction block. Okay, so let me draw this. So this is your RV, this is LV, left ventricle, right? This one is interventricular septum. I have only drawn the ventricle. Okay. So, you have a right branch, okay. This is AV node, okay. Bundle of His, it divides into left and right, right. Right bundle branch, and this is left bundle branch. It divides into the anterior fascicle and the posterior fascicle, right. Anterior fascicle and posterior fascicle, okay. Now, say there is a block in the right bundle branch, okay. Let me focus the conduction tissues, okay. So, there is a block over here, okay, correct. So, what will happen? So, normal rule is left ventricle and right ventricle will be depolarized simultaneously, okay. Action potential is coming from SA node to AV node, bundle of His, and then simultaneously both the ventricles are depolarized in this fashion, right. Now, there is a block here at the right bundle branch, here is a block, right. So, here is a block at right bundle branch, here is a block, right. So, what will happen? I told you that conduction tissues are nothing but modified myocardium which have got numerous gap junctions, right, which has got numerous gap junctions. So, they can conduct action potential faster than we expect, right. Okay. Normal myocardium can also transmit action potential from one cell to another, because all the myocardium have got your gap junctions. They can transmit action potential from one cell to the neighboring cell, okay. So, here what will happen? Once your right bundle branch is blocked, your left ventricle will be depolarized earlier, okay. Normal rule is both the ventricle will be depolarized simultaneously. This is normal rule, but once your right bundle branch is blocked and left bundle branch is okay, right. So, left ventricle will be depolarized fast, okay, FIRST fast. Left ventricle will be depolarized first, right. Now, after your left ventricle is depolarized, then, so left ventricle will be depolarized, first. Then, as this fiber is not okay, this conduction tarta kete geche, right. So, this conduction fiber is not okay. So, after from the left ventricle, depolarization will travel through normal path, through normal myocardium, not through these wirings. Wirings are not working for right ventricle. So, there is no wiring for right ventricle, but after this is depolarized, then it will move back and depolarize the right ventricle, okay. Normal rule is atrial depolarization, then RV plus LV एक साथ depolarization. This is normal rule, okay. But here what is happening in right bundle branch block? This is normal rule. Now, what is happening in RBBB? It is called right bundle branch block, okay. So, here what is happening? Atrial depolarization, फिर LV depolarization, फिर RV depolarization. Clear? What is the normal deviation? Correct? Okay. So, normally in here say for example, in lead V1, okay, lead V1, we see right bundle branch block in lead V1 and V2. So, what happens? So, after P wave is atrial depolarization. After P wave, you should have a QRS complex, right? You should have a QRS complex. But this QRS complex is broken. Okay, this QRS complex, normally the QRS complex is combined depolarization of left ventricle and right ventricle. Okay, normal QRS complex is the combined depolarization of left ventricle and right ventricle. But as because left ventricle is depolarizing earlier, followed by right ventricle, okay, पहले लेफ्ट वेंट्रिकल डिपोलराइज हो रहा है, नेक्स्ट उसके बाद राइट वेंट्रिकल डिपोलराइज हो रहा है. So QRS complex is broken down, separate for left ventricle and right ventricle. So you get a this thing, right? So QRS, total QRS complex is broken. Okay, you get one for left ventricle and one for right ventricle. Okay, so QRS complex is broken down. You get one for one peak for left ventricle and one peak for right ventricle, and we call it the M pattern. Okay, you see this M. Okay, this is M pattern. Okay, M pattern. Okay, now identify a real ECG from a patient of right bundle branch block. See, this is right bundle branch block, and where to see right bundle branch block? V1, V2. Okay, check the M pattern over here, check the M pattern over here. V1, V2. Getting M pattern, right? This is M pattern. This is from a patient of right bundle branch block. Okay, it is also here in V3, but ideally you will check in V1, V2, right? Clear? So this is right bundle branch block. Clear? Why do we check in V1 and V2? Because V1 and V2 more focused towards right ventricle. Clear? Okay, now left bundle branch block. Okay, so again, so here now this left bundle branch block. So again the same thing will happen. See, what is the purpose of this conduction tissues? To transmit action potential faster, right? Sit down. Conduction tissues अगर नहीं होता तो क्या होता? फिर भी होता, right? Because normal myocardial cells are also having their gap junctions. Okay, so one cell to one cell action potential travel is possible. ठीक है? So what is the purpose of wiring? यहाँ से wiring वहाँ से वहाँ पर AC तक, ठीक है? The purpose of wiring is to transmit electricity faster. ठीक है? In heart, the thing is, in case the wirings were missing, okay, wirings अगर नहीं होता, तो भी action potential can travel or electricity can travel. So you can consider all the bricks in the wall, they can transmit electricity. That means यहाँ पर मैं अगर electrical charge देता हूँ, तो वहाँ पर पहुँच जाएगा, but slow. But if I connect it with a copper wire, it will be faster. Clear? Now the thing is, this wire is broken due to many disease process, due to fibrosis, due to previous infection, right? So this wire is broken, this wiring is broken, but still action potential can travel. But once the tissue is fibrosed, the cell is not normal, it can travel, right? Okay, so the wiring is present here, this wiring is present, but this wiring is cut, right? The wiring in the left ventricle is present, the wirings in the right ventricle is cut. So your left ventricle will be depolarized faster. Okay. Now from the left ventricle, cell to cell depolarization hote hote, it will come to right ventricle. So this is why your left ventricle will be depolarized pehle. Okay. So left ventricle will be depolarized earlier than the right ventricle, and the QRS complex will be dissociated. Okay, one QRS complex will be for left ventricle, and next another QRS complex will be for right ventricle. Okay, so you get a dissociated QRS complex pattern, correct? Again, you can think of this with the vector theory as well. So here is the V1. So fast depolarization is here. Okay, fast depolarization is here, negative wave, and next depolarization is here. You get a positive wave, right? In this way, you can consider it with the vector theory as well. Okay. Now move to left ventricular or left bundle branch block. Okay. The same thing, the M pattern, again here the left bundle branch is block, It is usually uncommon because usually the anterior fascicle, as you know that left bundle branch is again branched into anterior fascicle and posterior fascicle. Okay. Usually it is common in the anterior fascicle to get a block, right. So anyway, if there is block in the left bundle branch, okay, and right bundle is okay, only there is a block in the left bundle branch. Now what will happen? Similar to the previous one. So right ventricle will be depolarized first, okay. Right ventricle will be depolarized first, then there will be depolarization of your left ventricle. And another thing, if you remember the septal wave, the small septal wave, septal vector, okay. We had many vectors, we had 5 vectors if you remember, okay. So first vector is the atrial depolarization vector, second vector is the left to right within the interventricular septum, right. So here this left to right will not be possible because this wire is not working, right. The left bundle branch, this is not working due to an injury or cut in this fiber. So instead of left to right, the ventricular septum will be depolarized from right to left, okay. So finally the right ventricle will be depolarized first, and through the normal myocardium, finally the left ventricle will be depolarized, okay. So in right bundle branch block, left ventricle will be depolarized first, then left ventricle, and in case of left bundle branch block, right ventricle will be depolarized first, then left ventricle. Clear? This is the thing. And here you need to find similar M pattern in the ECG, but not in V1, V2, in the ECG lead which is close to left ventricle, that is V5 and V6. So you see V5, V6, and you can clearly check the M pattern over here. Clear? Okay. So again in your examination, you should be able to identify ECGs of left bundle branch block and right bundle branch block, okay. So there is a mnemonic to remember left bundle branch block and right bundle branch block, but this is very classical. So if you remember this thing, William Marrow, okay, V1, V6, okay. So in left bundle branch block, you get M pattern in V6, in right bundle branch block, you get M pattern in V1. Clear? So where do you get M pattern in bundle branch block? This is simply a mnemonic, right? So if you remember this William Marrow, so you get this RR is for right bundle branch and this LL is for left bundle branch block, okay. So in right bundle branch block, you get M pattern in V1. In left bundle branch block, you get M pattern in V6, okay. Clear everyone? So we have covered heart block, okay. For your practical examination, you need to identify ECGs of first degree heart block, second degree heart block, third degree heart block, left bundle branch block and right bundle branch block, LBBB and RBBB. Clear? Okay. So myocardial infarction or acute coronary syndrome, ECG changes in acute coronary syndrome and ECG changes in heart block. These two topics are covered. Okay. Okay. Now we will move on to okay, one thing I had skipped during the lectures of normal ECG that I'll cover today. So this is the augmented leads and axis determination from an ECG. Okay, axis determination from an ECG. So let us do this axis determination from an ECG. Okay. So by now you know that ECG axis and the normal range of ECG axis is -30 to +110, degree, right? Okay. So here is, this is 0 degree, right? This is 0 degree and this is orientation of lead 1. This one is lead 2. This one 3. This one AVF. This one okay. So this is 0 degree and say this is plus 110. Okay. Now this area is the range of normal axis, that means resultant of all vectors, okay, resultant of all 5 vectors. Okay. So if your cardiac axis is within this, then ECG axis is normal. Okay. Now from an ECG, how to identify the direction of an axis, whether the axis is normal or the axis is abnormal. Okay. Here is the normal axis. If an axis is oriented in this way, it is normal axis, right? Once this is minus 30, so this area is covered also. Minus 30 to plus 110. Okay. So once the axis is within this range, it is normal axis. Once the axis moves in this direction, it is left axis deviation, and once the axis moves in this direction, it is right axis deviation. Okay. The cause of right axis deviation is right ventricular hypertrophy. The cause of left axis deviation is either left anterior hemiblock, okay, that is LBBB, left bundle branch block, इसमें हो सकता है, okay, left anterior hemiblock particularly, and also left ventricular hypertrophy. Okay. Now from an ECG, very quickly you need to identify a case of left axis deviation and right axis deviation. Okay. Left axis deviation and right axis deviation. So there are two procedures in the clinic. In the clinic, very quickly you need to check the ECG strip, and you need to see the ECG wave and determine the cardiac axis, whether the axis is normal or left axis deviation or right axis deviation. Okay. So to do this, we have a rule which is called the thumb rule. Okay. Thumb rule. And two ECG leads you need to focus on. One is lead 1 and another is lead AVF. Why? Because see, lead 1 and lead AVF, these are at right angle. Okay. Lead 1 and lead AVF, these two leads are at right angle. Correct? Okay. So you need to take out your two thumbs. Okay. You need to take out your two thumbs. Okay. So yes. So lead 1, you need to check the QRS complex, whether it is predominantly upwards or predominantly downwards. Okay. So check lead 1, check your lead 1. So QRS complex is predominantly upwards or downwards? Upwards. So lead 1 is your left thumb, lead AVF is your right thumb. Okay. So lead 1 QRS complex is predominantly upwards. Okay. So left thumb up. Okay. Now check AVF. This is lead AVF. This is lead AVF. QRS complex is predominantly upwards or downwards? Upwards. So left thumb up, right thumb up, dono up. So QRS complex, so ECG axis is normal. Okay. Axis is normal. Left thumb up, right thumb up, right? Normal axis. Clear? Okay. Very important question in your practical examination. With an ECG, you need to identify cardiac axis. So in this ECG, जिसका भी हो, in this ECG cardiac axis is normal. ठीक है? Next, lead 1, left thumb up or down, left thumb up or down, lead 1, left thumb up, okay. Lead 2, AVF, AVF QRS complex is down, so right thumb down, okay. Left thumb up, right thumb down, okay. Left thumb up, right thumb down, okay. So what to do? Left thumb up मतलब कि like button और this is dislike button, ठीक है? Like button, dislike button, okay. We'll not dislike anything, okay. We are good, right? We will not dislike anything. So your left thumb up, we are with this, so left axis deviation, clear? Okay. Up, left thumb up, right thumb down, okay, clear? Okay, left axis deviation, that means it is a case of left anterior hemiblock or left bundle branch block, right? Left side a conduction block ache, or it might be a case of left ventricular hypertrophy. Left ventricular hypertrophy is not here because there are separate voltage criteria for left ventricular hypertrophy. So this might be a case of left anterior hemiblock. Anyway, the major thing for you is to identify the left axis deviation, okay. So this is a case of left axis deviation, left thumb up, right thumb down. We will not go with this is dislike, we will like it only. So left axis deviation, okay. Next, this is lead 1, QRS complex ऊपर में भी थोड़ा सा है, नीचे भी थोड़ा सा है, right? Predominantly it is upwards or downwards? Downwards. So plus minus करके it is down because down में ज़्यादा है, right? Down में it is more than 5 squares and here it is 4 square almost, right? Okay. So it is predominantly downwards, okay? Predominantly downwards. So left thumb down. Now check AVF, QRS complex is upwards. This is which axis deviation? Right axis deviation. We will not go with this, we'll never dislike anything, we like everything, okay. So right thumb up and the case is right axis deviation and it is a case of right ventricular hypertrophy, okay. Okay. Anyway, no need to mention the diagnosis, what is the diagnosis, at least you need to identify whether it is left axis deviation or right axis deviation, clear? See this ECG, lead 1, down, okay, lead 1 down, lead AVF, what to do? Okay, this is extremely uncommon, this is northwest axis where the axis is in this zone, right, in this zone, northwest, okay. यहाँ पर अगर इंडिया का मैप करोगे तो यहाँ पर जो नॉर्थ वेस्टर्न स्टेट हरियाणा पंजाब ये सब आ जाएगा, right? So this is northwest zone, okay. So northwest deviation is very uncommon, anyway you don't need to know right now about northwest deviation of axis and it will also not expected in your examination. What you need to remember is the normal axis, left axis and right axis, okay. This much is absolutely for you, okay. Okay. Now another thing that comes in your physiology practical right now, we are just from an ECG, we are just calculating an ECG axis, okay, and you can very well tell that whether it is left axis deviation or right axis deviation, okay. Once it is left axis deviation means it is beyond minus 30 degree, minus 50, minus 60, this is left axis deviation, and once it is right axis deviation, it is here, okay, it is beyond plus 110 degree, right? It may be plus 120, plus 130, plus 150, right? So it is right axis deviation, okay. But can you tell the exact degree of the axis from this thumb rule? No. We just know whether it is left axis or right axis. But if I ask you exactly calculate the degree of axis, okay, it is 90 degree or 110 degree or 120 degree or minus 20 degree, what? How much degree? Okay, exact direction of the axis. If I ask you, then there is a geometric way to calculate this thing, okay. So for this, you need to take two leads. It is given in your physiology book quite well. So this is lead 1, right? Lead 1, okay, and this is lead 2, okay. Take these two leads, okay, lead 1, lead 2, and lead 1 को आप extend करो behind, so it is negative lead 1, okay, and this is lead 2, इसको भी extend करो beyond, this is negative lead 2, right? Clear? Okay. Now take any ECG from this. Say for example this one, this ECG, take this ECG, okay. Take this ECG. Now here lead 1, okay. Lead 1 में आप क्या देख रहे हो? QRS कॉम्प्लेक्स थोड़ा सा प्लस भी है, थोड़ा सा माइनस भी है, ठीक है, अप स्ट्रोक भी है, डाउन स्ट्रोक भी है. सो यहाँ पर एग्जैक्ट कैलकुलेशन करना पड़ेगा, सीइंग द ECG, राइट. सो यहाँ पर पॉजिटिव स्मॉल 4 स्क्वायर्स आर देयर, ओके, एज्यूम इट इज स्मॉल 4 स्क्वायर, 4 स्क्वायर ऊपर है बेस लाइन, एंड हियर इट इज 6 स्मॉल स्क्वायर्स नीचे है, ठीक है. सो प्लस 4 माइनस 6, okay. So in lead 1 you see plus 4 minus 6, right? Plus 4 minus 6, okay. So what is the resultant? Minus 2, clear? Okay. Now every in your paper, every half centimeter you draw in this way. Graduations, every half centimeter or 1 centimeter you can take, right. So again in the negative direction as well, okay. So this one is plus 1, plus 2, plus 3, in this direction it is minus 1, minus 2 in this way, right. So here in lead 1 we are getting minus 2, correct. In lead 1 we are getting minus 2, so here is minus 1, this center point is 0, here is minus 2. So we are getting this point, clear? Okay? Everyone okay with this? Okay. Now check lead 2, okay. Check lead 2, we have 3 plus 3, 6 up and 2 down, okay. Okay. So 6 plus 2 down, lead 2. So in lead 2 you are getting, lead 2 you are getting how much? 6 plus and 2 down, okay. In lead 2 you are getting 6 plus 2 down, clear? So plus 6 minus 2, so the resultant is plus 4, okay. So this is lead to positive direction, this is lead to negative direction. So in lead to 1, 2, 3, 4. So here you get the point. Clear? Okay. Now you need to draw verticals. Okay. यहाँ पर एक vertical आप draw करोगे. Okay. You need to draw a vertical through this point, and you need to draw a vertical from this point. Clear? Okay, and these two things they will intersect in this point, okay. They will intersect in this point, okay. Now, where is the center point where lead 1 and lead 2 are crossing? Here is the center point where lead 1 and lead 2 are crossing, or the 0 point. Okay? Clear? Now, you connect this with this. Okay? So, here is the axis, here is the ECG axis, clear? If I draw afresh, ECG axis is this, clear? Clear everyone? Here is the ECG axis. So, definitely it is more than 90 degree because this one is 90 degree, this one is plus 90, okay? This one is plus 90 degree. So, it is even beyond more than 110 degree, it seems, okay? So, it is right axis. Now, you measure this angle with a protractor, okay? This is the angle you need to measure with a protractor, right? If you measure this angle theta, it will be the cardiac axis, and you see definitely it is more than 110 degree, and it is a case of right axis deviation, and in our thumb rule also it is right axis deviation. Clear? Okay. So, by seeing an ECG strip, you are to identify whether it is left axis deviation or right axis deviation. You just apply thumb rule, and in the clinic we usually do so, right? In the clinic we usually do so because the exact degree is not required in the clinic, because in the clinic if you were to draw vertices and the patient will be waiting, they will just slap you, right? Okay, you will be drawing, you will use a scale, a ruler, a protractor, okay. So, your patient will tell, Doctor Sahab, आप क्या कर रहे हो? आप mathematics कर रहे हो कि आप doctor हो, ठीक है? So, anyway, nobody will ask you the exact cardiac axis in your clinic, but for examination purpose you need to know, right? For examination purpose you need to know, you need to identify the exact degree, okay. So, depending on the question, if your question is identify the axis, left axis or right axis, then just apply thumb rule, and if your examiner asks you accurately calculate the cardiac axis, you apply this simple geometry, right? Okay. So, in your practical examination, ECG strip will be given to you, right? Check lead 1 and lead 2, plus minus calculate and draw these vertices and their intersecting point, connect it with the center point, you get the axis, okay. And in your practical examination, in physiology practical examination, you need to bring these things, your rulers, protractor, to determine the cardiac axis, okay. It is at least 5 marks question in your practical examination.